Hello, my name is Dr. Natasha Datoo, and I will be speaking to you today about pediatric palliative care. I am a pediatric oncologist and palliative care doctor in Vancouver, Canada. Our objectives today will be to review what is palliative care for children, when to initiate or start palliative care, which children can benefit from palliative care, how and what palliative care can do to help a child and their family, and how we can provide a palliative approach to care in various different settings. So what is palliative care for children? It is an interdisciplinary collaboration that seeks to improve the quality of life of all children with life-threatening conditions, as well as their families. Palliative care for children also focuses on prevention and the relief of suffering, regardless of the stage of the disease, and comprehensively addresses the physical, psychosocial, or spiritual needs of a child and family. And these are some of the definitions used internationally for pediatric palliative care. To me, pediatric palliative care involves caring for not only the child's physical well-being, but also their social, spiritual, emotional well-being, as well as that of their families. In pediatric palliative care, we focus on a few things, including the prevention and treatment of pain and other physical symptoms, psychosocial and spiritual concerns for children with serious or life-threatening conditions, as well as their families. Pediatric palliative care is not only limited to the last few days or weeks of life. This is called the terminal phase or the end-of-life phase, and pediatric palliative care can absolutely help in these cases. However, we should try our best to involve pediatric palliative care early on in any child who has a serious illness. We should also note that pediatric palliative care can be given alongside disease-modifying treatments or active treatment. For example, a child undergoing chemotherapy who we know has a very serious illness and they may die from their disease should have palliative care involved at the same time as they are taking chemotherapy. We aim to improve or maintain the quality of life of the child and family. And as I mentioned, our goal is to provide holistic care: physical, psychological, spiritual, and social. Pediatric palliative care can be for patients who have cancer diagnoses, but there are a lot of other non-cancer diagnoses that can benefit from palliative care. It requires active care and sometimes intensive symptom management, and it is best provided by an interprofessional team, but anyone who cares for children and children with serious illnesses can learn skills to help provide pediatric palliative care. The history of pediatric palliative care continues to evolve, and in the last decade has made significant gains. Previously, early on, there were a lot more children dying of diseases that are now curable. The focus was solely on death, and often palliative care only became involved the last few hours of life and provided support for physical symptoms. As the years went on, people caring for dying children realized that there was much more than physical suffering of the child. A child with a serious illness who is dying or who may die has much more components to their suffering, including the family and the siblings as well as physical and emotional suffering of their own selves. Medical teams realized that having an extra care team, such as a palliative care team, could benefit these children and their families. And the birth of what we call pediatric palliative care now has come about, where we are trying our best to be involved early on to support families. When is it appropriate to start pediatric palliative care? The American Academy of Pediatrics states that pediatric palliative care should be offered at diagnoses and continued throughout the course of illness, whether the outcomes end in cure or death. Providing pediatric palliative care can be done alongside treatments that might cure the child. This is very common in cancer patients, but also non-cancer patients, such as patients with metabolic disorders or neurologic disorders who are actively receiving disease-modifying treatments, but we aren't sure if a cure is possible, and we know they have a serious illness. This is the newest model for pediatric palliative care. A child is diagnosed with a serious illness or a life-threatening illness, and the goal is to cure or control the disease. Disease-modifying treatments are often started. This can be chemotherapy for cancer, antiretrovirals for HIV, antibiotics for serious infections such as tuberculosis, or metabolic medications for neuromuscular diseases. Initially, the goal and focus is on these disease-modifying treatments. However, if this is a serious illness, the pediatric palliative care team can and should be introduced early on. However, the role of that team is often in the background and much less active initially. As the disease progresses, the shift happens between focusing solely on disease-modifying treatments to also focusing on supportive care and symptom management. However, this does not mean that active treatment of the diseases needs to stop. The palliative care team often becomes much more involved in this second phase. However, having built a relationship previously or been introduced to our team can be helpful. And of course, as patients continue to get sicker, the palliative care team hopefully now has built a relationship with family and can naturally become the primary care providers and assist with end-of-life care and death. Palliative care also should be involved post-death for bereavement support. As an oncologist, I often explain to the families I take care of and the children that I will be involving a palliative care team. And I often explain that palliative care is about hoping for the best, but planning for the worst. We all do this work with hope, and we all hope the child gets better or is cured, but we also want to be safe and plan for the worst. Some of the goals of pediatric palliative care are, in my opinion, the first and foremost goal is to have a child live and enjoy life as much as possible. To be able to feel well enough physically and spiritually and emotionally to continue to make connections with their family and their friends and loved ones. The goal is often to be at home or in a safe place outside of a hospital if possible. And we know that in certain situations or environments, shelter or a safe place is difficult. And in these situations, I think about where the child would feel the safest. And if that is in the mother's arms, that will be our goal. We hope that the child can continue to enjoy the things they love, playing, singing, drawing, and that families can also participate in this. Some of the most common myths about palliative care are very common, and a lot of families, caregivers, doctors, nurses all feel uncomfortable about palliative care. And so I would like to take a few minutes to break down these myths. We should not be saying nothing more can be done. This makes parents feel that we are giving up, that we have failed, that their child has failed. There is always something more that can be done. That includes active, aggressive symptom management to make children feel better. That includes finding ways to have families make connections together regardless of their environment. And that also includes focusing on what makes a child happy. We know, and there are studies to show, that when a child is doing something they enjoy, spending time with friends, they are happy, they often live longer. Palliative care is not only available when there is no disease-directed care possible. Palliative care is available when we are actively trying to treat disease, but we just aren't sure if it will work. Some may believe that involving palliative care may bring the child's death sooner, or that it must be given at home or in hospital. We know we can provide a palliative approach to care in any setting. Studies have shown that early palliative care improves quality of life. When people are feeling better and doing things that bring them joy, they live longer, and patients have fewer depressive symptoms. Now we will shift our focus to which children should receive palliative care. Palliative care should be offered to children living with life-threatening conditions or life-limiting illness with progression. What does life-limiting mean? These are conditions for which there's a likelihood of death before adulthood. A lot of times these include children with neurologic conditions or metabolic conditions, such as cerebral palsy. Life-limiting conditions are those for which curative treatments may be feasible, but also may fail. This includes cancer, as well as certain infectious diseases. Progression means the ongoing deterioration of health and or functional status of the child. Studies have shown that 55 per 100,000 children in South Asia need palliative care. And this is what we were just saying, that which conditions need palliative care? Children with ongoing progressive conditions, where deterioration of their health and abilities will continue on till death. Children with life-threatening conditions, such as cancer, or any child with significant pain or other symptoms which palliative care can help with. Now we will talk about 4 categories of children who need palliative care. We will go through them in some detail and give examples of children with this type of disorders. Category 1 includes children with any type of life-threatening illness where curative treatment is available but may fail. So certain examples are cancer, congenital or acquired heart disease, infections such as meningitis, malaria, TB, organ failure such as liver disease or kidney disease, certain blood disorders such as thalassemia or sickle cell, as well as prematurity. The illness trajectory in Category 1 is often more expected in children with serious illness and something people are more familiar with. This is a child with a potentially curable pediatric cancer. They're diagnosed, they receive curative treatment, they're in remission, then they have a relapse and they decline. They receive further treatment, they have a plateau, and then they have a very smooth decline towards death. This is more typical of a historical trajectory for death and when palliative care should be involved. Category 2. This is a long period of treatment which aims to prolong life, but premature death is anticipated. Examples of this include HIV/AIDS, cystic fibrosis, muscular dystrophy, spinal muscular atrophy, different neurologic muscular conditions, chronic severe respiratory failure, or severe immune deficiencies. The illness trajectory for these patients can be a little bit different. They have long periods of stability with their treatment. However, over time, they start to have further declines. They may end up in hospital for a respiratory illness or an aspiration pneumonia every winter. And over time, we see slow further decline until at one point, that last admission, they cannot recover from. Category 3 includes progressive conditions without any type of curative treatment option. These include chromosomal disorders, such as trisomy 13 or 18, very rare metabolic disorders where there's no disease-modifying treatment, and certain neurodegenerative conditions, such as Rett syndrome or leukodystrophy. The illness trajectory in these patients is again a little bit more predictable. They're diagnosed, they may have a period of stability, however there's no disease-modifying treatment, and therefore slowly the disease takes over and slowly they decline until death. Category 4 includes severe disability that leads to vulnerability to complications, which can lead to premature death. These are patients who have diseases that are static, but over time, their body starts to shut down. Cerebral palsy is one of these, patients in the more severe end. Severe brain injury due to trauma or hypoxic birth injury. Severe infections can cause this, or severe brain malformations. The illness trajectory in these disorders are again a little bit more up and down, a little bit more similar to category 2, where they have incurable neurodegenerative diseases and decline, where they decline, have a new baseline, decline more, have a new baseline, decline more, and eventually decline enough that they pass away. This is another way to look at what categories of patients who may benefit from pediatric palliative care. This is a simplified version of the 4 categories we just discussed, and these are all included in those previous categories, but this is a simple list that can be helpful. So any patient with cancer, a CNS condition, a biochemical metabolic disorder, neuromuscular, cardiac or pulmonary conditions, infectious diseases, immune problems, or anybody with a multi-organ condition due to problems with genes or chromosomal anomalies. This is a figure to show the distribution of children in need of palliative care at the end of life by disease categories. So as we were talking, the majority of pediatric deaths occur due to congenital anomalies, 25%, followed by neonatal conditions, including prematurity, malnutrition, meningitis, infectious diseases, including HIV, followed by cardiovascular diseases, blood immune disorders, which includes leukemia, cancer, and a smaller percentage of neurologic conditions and kidney and liver. Now we will shift our focus to how and where pediatric palliative care is provided. This is a pediatric palliative care framework that I use often when thinking about how to provide holistic care for a child and their families. We talk about their physical symptoms and how to manage them. We also talk about the child's emotional status, what they're like, what they enjoy, how they relay their information, as well as the social. What is the social circle around them? What is their community like? What is their family like? Their spiritual beliefs. This can include religion, but also cannot. And trajectory. How we plan for the future and possible end of life. Any of us who care for children with serious illness or life-threatening illness in any environment share a responsibility to provide palliative care or a palliative approach to care. It does not always require specialist-level pediatric palliative care teams. What I find is the most important is this base of the pyramid, where primary care providers, family physicians, any pediatrician or adult palliative care, or any person caring for children can provide a pediatric approach to palliative care. Now, how and where can we provide palliative care for children? The three most common locations where we can provide palliative care are where children are located during their serious illness. We can support in the home with community home care and community-based teams. We can support in hospitals. In community hospitals, sometimes there is an adult palliative care team that can assist. In larger tertiary care hospitals, there are at times pediatric palliative care teams. We also have hospices, which are buildings specifically to provide end-of-life and palliative care for adults or pediatrics. However, in any environment, I do believe that we can all provide parts of pediatric palliative care. And we will continue to talk about how we do this. Now, if we are in a tertiary care center or a big city, pediatric palliative care is best provided by a multidisciplinary team. We can provide community, hospital, and hospice-based support where we work together to support the child regardless of location. Depending on local resources, team members can be drawn from various different places. In terms of a core team, it can include a physician, a nurse, and a psychosocial support professional, such as a social worker, a psychologist, or a play therapist. Other team members that can be helpful, and if there is the option, would definitely be helpful, are pharmacists, occupational or physiotherapists, art, music, or recreational therapists, spiritual care, and volunteers. Pediatric palliative care is truly about teamwork. To be able to provide holistic care, we do need expertise from various different professionals and specialists. Volunteers in the community are a huge, huge asset to pediatric palliative care teams, as are community health workers and nurses. Some of the specific areas of pediatric palliative care include medical respite care. This is in a situation where we are in an environment where there is a pediatric hospice or care home where children are coming for respite, where families can get a break from caregiving. It also includes aggressive pain and symptom management at times, end-of-life care, community or home-based care, perinatal palliative care, grief and loss counseling, and bereavement care. What I think is very important to mention is we can all provide parts of pediatric palliative care and learn about a palliative approach to care. Being present, making connections, listening to the child and family, and playing with the child are a huge aspect of palliative care and allowing a child to live as best they can for as long as they can. Non-pharmacological symptom management and supportive care can be done by anyone, regardless of training or environment. So let's talk about how we can integrate the principles of pediatric palliative care into your practice or your environment. The palliative approach to care is extremely important and can be learned and taught to anyone. This includes generalist level palliative care with 4 basic principles: identifying needs or who would benefit from palliative care, assessing, planning, and managing. So we will talk through these. Identifying. This is the first step to integrating pediatric palliative care into your practice or your setting. Being able to identify the patients early on who may benefit from pediatric palliative care. So if you have a patient in any of those 4 categories that we previously talked about, having the knowledge to know that palliative care may help these patients is extremely important and the first step. Then assessing the patient and their family's understanding of their illness and information they've been given. Assessing their symptoms, their psychological, spiritual, emotional needs, assessing what their quality of life is right now, and also assessing their values, wishes, and preferences for what they're hoping for the future if their child were to get sicker. The third step is to plan. How do we plan for the future knowing a child will likely get sicker? We can do advanced care planning, which includes but is not limited to goals of care and care planning. How do we anticipate symptoms and plan for these based on parents' and child's values, wishes, and goals? We make treatment plans. We link families and children into resources and other care providers in their communities, and we prepare for emergencies with medications, documentation. And then we manage physical symptoms, we manage psychological, spiritual, emotional needs. We have hard conversations and enhanced communication, and we refer to other specialists if needed. We will talk about 3 key practices of a palliative approach to care for children and their families now. Practice point number 1, understanding the illness from the child and family's perspective. This is of utmost importance, and none of the rest of pediatric palliative care can be done without this key piece. There have been studies to tell us and show what parents of seriously ill children need from their care providers. The themes have always been common, and some of them include recognition from clinicians that they know their child best. I often explain to trainees that if a mother is worried, trust that. Even if you aren't worried, trust a mother's instinct. Parents want to feel and know that you believe that they are good parents. Even if the team and the parents disagree on the future plan or the next steps, parents still want to know that you truly believe they're good parents and are doing and feel what's best for their child. Parents want clear and honest information. They want information communicated in a caring and sensitive way. They do want to have trusting relationships with their clinicians. And they do want preparation for death. They do want to know if you are worried their child is dying. We also know that there have been studies asking children with serious illness what they need. They need reassurance that they will be looked after, that they are loved, will continue to be loved, and they will never be alone or scared. They need nurturing attention. They need simple but honest and age-appropriate information. And they need to play. Play is what children do, and play should always be part of a pediatric approach to palliative care. What is play? Play is one of the fundamental aspects of a palliative approach to care in children. Play is the most natural thing children do. As children start to crawl and walk, they start to play. And play should always continue to be a part of a child's care in hospital, at home, or in a hospice. Play is a safe outlet for children. It allows them to openly and honestly express their emotions. It allows them to escape from the stressful realities of what their life is, including treatment and meetings and being away from their friends. It allows them to make choices and have some control and succeed at things. And it also helps them to understand their life experiences. Play therapists are very, very skilled at helping children in all of these aspects with play, but any one of us, whoever is around children or cares for children, can play with a child. Practice point number 2 is how we give children and families the information they need. We saw in the previous slides that children and their families have all said and shown in studies that they need and want clear, honest information. So how do we do this? So how do we communicate honest, clear information to families in a way that is compassionate and caring? The first thing that we should always do is ask the family's understanding of where things are at with their child. I often ask, what is your understanding of what the oncologist said yesterday? Or, what do you know about what happened this morning? What do you understand about that? By asking a family's understanding or their perception and understanding of a meeting or a conversation or where their child's status is, will provide you with very, very helpful information and guide you in how much information to share and how to share that information. The second thing I always try to do is ask permission to share. Would it be okay if we sat down and talked about where things are at? Sometimes the family will say, right now is not a good time because my husband's not here or father's not here. So we should always ask permission. It also gives families a warning shot that we're going to have a serious conversation. I also like to ask families how they like to have information shared with them. Some families, for example, like to see photos. They like to see scans. They like to see CT scans or x-rays. Other families do not. So that will help you in knowing that. As we said, families want clear, honest information including prognostic information. They do want to know if you are worried about their child. One approach that has been shown to be helpful to care providers who are not as experienced or who don't have serious conversations that frequently is the wish, worry, wonder approach. An example would be, I wish that your child will get better. I worry, based on their breathing changes or their increasing pain, that they are getting sicker. I wonder if we can talk about some ways that we can help make your child more comfortable. Although we can never predict time, families can ask, and often do ask, when will my child die? How soon will it be? None of us have the privilege to know time, but it is important to give some type of containment to the situation based on the objective changes you are seeing in a child and their progression or trajectory. So if you are seeing changes you are worried about, it is important to communicate those, but having no prediction of true time periods. I often get asked by families, will the child be there for their birthday? I often express, I hope they're here for their birthday, but if I feel they won't be, I can say, I worry time is shorter. I wonder if we should plan an early birthday party. Or, will my child be here for the fall? You can say, I worry they won't. Let's try and have a great summertime. Communicating honest information about prognosis does not take away hope. I always express to families, I hope so much their child lives as long as possible. Hope is a very important thing, and studies have shown by being honest with families, we can still provide hope. This was a study to show you that communicating honest information about a child's prognosis, even if you're sharing your worried time is short, does not take away hope from families. In this study, patients were asked about how hopeful they were prior to information being given and then after information was given, specifically information about prognosis. All families had the same amount of hope before and after. What we do know is families trust you if you're able to provide honest information about prognosis. Our third practice point is providing you a practical approach to how we provide goal-directed care to pediatric patients with serious illness. Pain and symptom management is very important for a palliative approach to care. This can be near the terminal end-of-life phase, but also for children who have chronic disorders and may have symptoms including reflux, feeding intolerance, neuroirritability, or pain. Pain and symptoms can be forgotten in children with serious illness, and myths do exist that babies or children do not feel pain, and this is false. Many physicians do not feel comfortable using opioids in children. Opioids are very safe and effective when prescribed by a skilled provider for the right reasons. Palliative care involves expertise in symptom management. We also need to be mindful of how to assess children who are not able to communicate verbally. We need other cues, such as grimacing on the face, vomiting, clutching the fists, not tolerating feeds. These are all signs in nonverbal children that they are not comfortable. And palliative care experts or people providing a palliative approach to care need to be mindful on how to recognize these so we can then treat and alleviate symptoms and suffering. Near the end of life, there are a lot of common symptoms. Pain is very common near end of life, and again, opioids are very important and safe when used by physicians or team members who know how to prescribe them for pain. Fatigue is also common. Poor appetite and nausea and vomiting can occur. Patients can have swallowing problems and may require medications given through other routes than oral. Bowel habits and shortness in breath and dyspnea are also common near end of life. I will say opioids at half dose for pain, 50% of dosing for pain, are very effective for shortness of breath and dyspnea near end of life. And since our goal is to alleviate suffering, if we are using medications safely to help with symptoms, this is a palliative approach to care. Home-based care, or care outside of a hospital or hospice, are often very common in different parts of the world. To me, home-based care can occur wherever the child or family may be. We have home-based care teams and people that can visit the child and family frequently, wherever they are, to at least be able to assess the symptoms and potentially provide symptom management and end-of-life care with support. There are many teams led by community health workers with phone support and visits from doctors and nurses that can occur in the home or wherever families are. If care becomes too difficult or symptoms cannot be managed in the home, that is a reason for the child to be brought to hospital for end-of-life care. So the role and skills of all healthcare providers can be used to help alleviate suffering in children with serious illness and assist with a palliative approach to care. An integrative approach is needed, recognizing that palliative care should start at the time of diagnosis for so many different health conditions in children. I feel that this is absolutely the very first step, is recognizing what children could benefit from a palliative approach to care and disseminating this information to all care providers. A willingness to be open and honest with families and communicate with families to help them understand their child's illness and how palliative care can support them to be comfortable and live as long as possible. And goal-directed care with good pain and symptom management will ensure that the child receives the best treatment for their suffering. And if a child is comfortable, they often live longer. Some of the key points that we've learned today is we cannot add days to a child's life, but we can add life to their remaining days. We have learned about palliative care and what palliative care is for children, as well as what a palliative approach to care is. It is an active and total approach to care for the physical, emotional, social, and psychological needs of a child and their family, to focus on their quality of life as best as possible, and to provide care to the entire family. We have also learned about who qualifies for palliative care services. We have learned that any child with life-threatening or life-limiting illness could benefit from palliative care. How can palliative care help a child and family? We have learned that good pain and symptom management and alleviating physical suffering can be beneficial to the child and family. We've learned about hospital and home-based support and care. And again, we have learned about providing holistic care to children and their families. This is Joanne Wolfe on the left. She was the keynote speaker for the 4th Global Gathering of Congress on Pediatric Palliative Care in Rome 2018. Dr. Joanne Wolfe is a pediatric oncologist and palliative care physician in the U.S. and is an expert in communication. She quoted Dr. Ann Goldman, who was a physician who established the very first hospital-based pediatric palliative care service for children in 1986. And Dr. Goldman said, and I quote, "I hope that in the future, as well as caring for individual children and the families, the philosophy and practice of palliative care will become a beacon of good clinical practice, genuine communication, and humane care among all clinicians." Thank you for listening, and I hope that you will continue to engage with us for this workshop and learn together about how we can care for children and their families with serious illness. Thank you.